And now, because you jumped ahead a little bit, you talked to the degludec liraglutide product studies, if you will, and the FDA did that. It was a dual phase 3 trial, right? So now that's a different combination of drugs. Right. Why is that different? What is the difference among all
Well,
three of these?
I already mentioned.
Yeah, but I want you to just parse it out once more.
Okay. The dual is the combination of degludec plus liraglutide.
Right.
They have a vast greater development program than the Lixilan. The Lixilan is interesting. They got approved with 2 studies. They did like 6 different studies. But the really ones that are comparable between the 2 is the Lixilan O with the dual 1 and the Lixilan L with the dual 2.
Right.
Because they are testing the combination versus each individual component. And the dual 2 is testing that the combination versus the degludec plus liraglutide versus degludec alone.
And spell it out. Where are we with the dual trials compared to these?
Well, just basically, this is what I said, is it was about a 0.7% difference when you added liraglutide to degludec versus degludec alone.
Yeah, and some vary. They could be 0.5% and so on.
Depends which
and so
study
forth.
you're talking about.
Right. Yeah. But I guess what I'm asking is, if you're going to take a look at the Lixilan trials versus the degludec trials, can you compare them?
No,
You can't.
That's what I wanted to hear.
No,
No,
the
but
only
it's
way to
very-
do that, Peter, is head-to-head. And that's unlikely going to happen. But to me, they are both very effective. I think they're both going to be valuable to the primary care provider who is using basal insulin and not getting the patient where they need to go. With a simple, as Carol has said, with a very simple transition, because it's again a similar pen, titratable pen, very small needle, and with excellent efficacy.
But Peter, I think you're asking when would you choose this one versus that one.
That's
So
where
let
we're
me
gonna go with the
let me
next
spell it
question,
out
actually,
my
yes.
way based on the current recommendation.
Take a practitioner through this. Who wants to-
If you have a patient, the FDA says you've got to put them, you've got to use the combination in somebody who's already on one of these. There are not that many people on lixisenatide since it's new, but there are a lot of people on Lantus who are not controlled. So to me, it means if I got someone on Lantus who's poorly controlled and I need to add a GLP-1, I would use Lixilan. On the other hand, there are not that many people on degludec because it's new, but there are a lot of people on liraglutide and they need insulin. I would use that combination.
Or they
That
can't
way
take
I'm
it.
satisfying the FDA. I hope, though, with time and with more trials, the FDA will say, you know, this is the way to use the first injectable. Choose whatever one you like and give it to people who are failing on oral agents.
But there is a conceptual difference, though. I mean, the conceptual difference is in the GLP-1 primarily. It's also the insulin. But the GLP-1 with the Iglar-Lixi is a rapidly acting GLP-1, which is mainly going to affect gastric emptying and postprandial glucose. The liraglutide component with degludec is going to affect the basal, the preprandial. So it matters which is most abnormal in the patients. If the patient has good glucose control except for an elevated postprandial after breakfast, which is very common, then it would be ideal to use Iglar-Lixi. If the person is on liraglutide or on glargine and not doing well, you could easily add the combination of degludec and liraglutide to get the whole basal down.
You know, and you can, you know, we like to sometimes sound smart and come with some sophisticated.
Oh, you are smart.
Yeah, yeah, a little bit, but and come with some rationale. Okay, the rationale is spelled out. As they said, first of all, those are drugs that are given in the morning, which makes a lot of sense because you check your blood sugar in the morning, you'd make the changes. They're right there. Before we were using that drug at night, in the evening, and that's probably not the great idea. But you give it in the morning, you know with Lixi you're going to knock down the postprandial at breakfast for sure, and a little bit at lunch. As Bob Henry said, with liraglutide you have overall coverage, you lower the fasting, and you have carryover effect. That's why you see a difference on insulin, because when you are using Lixilan, you are adjusting the basal insulin, the Lixilan, according to the fasting. With the Ideglira, you have a little bit of help with the basal insulin, to the basal insulin. That's why you end up using much less. And then you have the carryover. In the end, bottom line, both are effective. What is going to be a major difference in my little mind is that is the fact that with one has the rule of the 30s. So when you're using 42 units and you do the switch, you go down to 30. It's a little bit more comfort zone. No going from 42 to 16. And despite the fact that you didn't see a problem in the studies with that, in the real world may be some disenchantment there. But to give you the final word, you know who's going to decide? Regardless of the head-to-head studies, whatever they're going to show, there's probably not much difference. Regardless of all the smart rationale, the formularies. Whatever is in the formulary is what the practicing physician is going to use.
I really like Vivian's approach, though. You look at what the patient's on, and I had a patient yesterday who I made the decision to change to the combination of iGlar Lixie. But she was on glargine insulin. Her fasting glucose looked better than her A1C. I knew she needed postprandial, and it was simple.
Let me ask this question before we run out of time. Let's fast forward 5 years and assume, and that may not be a good assumption, that no new research. These are the products that are out there. These are the products people are going to use. Someone comes in de novo, type 2 diabetes. What are you going to start them on? Type 2 diabetes, de novo diagnosis, comes to you. What are you going to give them? First day you see him, here's your therapy.
Well, I mean, the first thing I'm going to do is sit down and talk with him about lifestyle modification with the new onset diabetic because, I mean, depending on his A1C, if he comes in with you or she comes in with an A1C of 11, it's going to be very different than if they're 6.9. Right. My attitude is going to be totally different. All of them are still going to get the same kind of information on lifestyle modification, but obviously my aggression towards treatment is going to be different. With someone with an A1C that's less than 7 or it's in the low 7s, one has the opportunity to see some effects of lifestyle modification. But I still would probably start metformin right away. That's what I would start them on.
And you've got this smile.
So in the A1C that was in the lower range, I would probably, I hate to say this, agree with Julio and start on a combination metformin.
Should we just stop right now,
Yes.
declare victory, and get out?
Yeah. But I would be tempted.
Metformin and what?
And an SGLT2 combo drug.
Yeah, but all their failures will then come to me, and I will add in one of the GLP-1 insulin combinations.
So I was just going to say, if my patient was the 11%, I would start them on metformin and one of these agents.
Can I give you my last word?
Well, in a moment, we're going to get to your last word.
Okay, I'll give you my last
And by the way, why do I suspect you never have really a last word?